Good morning. It's lovely to be here and excited to have this conversation about philanthropy and the neglected tropical diseases. I've been at the Bill and Melinda Gates Foundation for about 7.5 years working in this space, so I've watched it evolve over the time, and it's been very exciting. I think I'm one of the few presenters that actually have slides, and because we have a lot of data around this, I wanted to put out a series of different points for thought, and then hopefully the rest of the panelists can take those and develop on those as we move forward. So, next one. All right. So first off, the basic overview of this is that, okay, NTDs, our programs, they work, okay? We have something that actually has impact in the field, and we know that we can do it, and so now we need to make sure we get it to everybody who needs it. We know we can do it. In 2012, 807 million people were reached with mass drug administration programs. So this is a program at a scale that's never been seen on the planet before, and so we know how to do this, but we've got to double that figure in order to actually reach the number of people who need to be reached with preventative chemotherapy. It has impact. And I'll show some slides on that. And then in order to do this scale up, we're going to need to be inventive and creative and work together to be able to do that. And basically, I have 3 different categories of thinking about that: increasing the efficiency of programs, aligning our advocacy so that we have a stronger voice by working together, and the third piece of increasing our resources and where can those resources come from. So my first slide as the first speaker within this space is just an overview of the NTDs. When we look at this, there's more than 1 billion people around the planet suffer from NTDs or are at risk. They range from parasites to bacteria, and they have 2 main elements at which we fight these diseases. One is through mass drug administration, where we find out communities' level of disease, and then we treat basically everyone in the community level with drugs that are donated by the pharmaceutical partners to treat, and it both treats and prevents the disease from and blocking transmission. We have a second group of diseases, which is they're called the innovative disease management diseases, which rely on screening and treating. So you have to screen everybody within a community, find out who's sick, and then treat them. And again, a lot of those diseases have partial, if not total, donation programs for those. And so we come into this space with a lot of resources already on the table. When you look at this, the prevalence of disease, the DALYs, the disability-adjusted life years, these are the most common diseases of people who live in poverty around the world. And so when we're trying to reach this, we have very ambitious targets, trying to reach approximately 1.4 billion, you'll hear slightly different figures, but people around the world with these programs. So it's very ambitious. So this is just evidence that I'm focusing a lot of my conversation on the mass drug administration aspects of the NTD programs, which deals with 5 of these, or 7, depending on how you count the intestinal worms, which have more than 1. But basically, this is data from trachoma in Morocco. This is a bacterial infection, and basically showing that as you treat, the disease goes down. Similar, we have this with river blindness in Nigeria. As you treat, you have improvements of disease with nodules, visual impairment, popular dermatitis, and leopard skin decreasing. And then schistosomiasis in Cambodia, also showing that as you treat, it goes down. And soil-transmitted helminths in Zanzibar. So we have therapies that work. We know that they will affect community-level disease transmission, so now we just need to get these out. So moving from that to where we stand, the evolution of time and things that have been happening in the NTD space, there's a lot going on. If you look at the top, these are all policy-related pieces, and if you look at the bottom, these are donations either of drugs or of dollars going into the space. So this is rapidly evolving, starting from 2005 to where we are now. Many, many, many different activities, many things moving forward and changing the field that we work in. So one of the things that's really compelling about the NTDs is the fact that we have a very unique relationship with the pharmaceutical industry. And so when you look at the amount of drug, and this is going from 2014 to 2020, the commitments that were made and previously and expanded through the London Declaration on NTDs, we have an amazing amount of pharmaceutical products that have been committed to fill the gap. So when we look at our program costs up here, we have resources, domestic resources that are available in the purple. We have the funding gap is in the green. When you look at that, actually the amount of resources we need to leverage is so tiny compared to the amount of resources that are already on the table. This is a very compelling message to say that your dollar goes so much further. And I think when we start to talk about engaging philanthropists, that has to be a core piece of our message. And I know for my organization, it's been very compelling, and the interest in working very closely with our industry partners and seeing them as part of the solution and not part of the problem. And that has been extremely true when it comes to the NTDs, where our pharmaceutical partners are actively engaged. So the Gates Foundation, that's what BMGF is, Bill and Melinda Gates Foundation, made our first investment in 1999, and I think the person who got that is probably sitting right about there. And we made investments in a number of the different NTDs with looking at how to leverage those and some integration. In 2005, we were convinced that integration is the way to go, because instead of having Schisto try to reach people here, STH try to reach people here, Onco trying to reach people there, when basically all of these communities are co-endemic, all of them suffer from more than one of these diseases. We bring them together, we have more value, we reach more people. So we started doing this. USAID then said, hey, that's a pretty interesting idea. And there was a lot of advocacy that went from the community to push forward this idea. And they put in a little bit of money to see, and oh my gosh, it worked. And they actually exceeded every target that they had set, which then increased their investment and got DFID to come in. So DFID then puts their investment in, tests the water for a couple of years, then says, wow, this is really having the impact that we thought it did. And they increase their commitments as well. So as you see, and this is just 3 of the donors that are working in this space, there are more resources going in, but this is an idea of how evidence and how making the case compel others to move in and take action. So that's great, more dollars coming in, et cetera. But we actually still have quite a significant funding gap. And so when we come into 2012, going to 2020, we see that we've scaled up a lot, but in order to actually hit the WHO targets, we don't need to be on this line, which is where we are currently. We need to be on this line. And to do that, we need to get a significant amount of resources. And that's very challenging when we talk about our resource gap here, which is about $220 million per year. From an NTD perspective is big, but from an overall global perspective is small. Well, we did pretty good in 2012, almost there, but we need to continue that trajectory in order to actually hit these 2020 targets, which we've talked about trying to do. So the blue line here is just to show you that more resources are coming into the space, so there is progress being made, but we still have to get the rest of that green filled in with dollars in order to be able to do this. So I think one of the things is how do we do that? How do we fill that gap? Well, what are the primary drivers for the costs within these programs? And again, this is taking an MDA perspective and just understanding where these costs come in. And there are many different things, but most of these programs are delivered by volunteers and people at the community level. So a lot of the delivery costs are these per diems and pieces of getting having those people actually delivering at the community level. But one of the things that we've learned is that through this integration, again, not having programs run in parallel, we can have a huge impact. So this is information from Mali, where with integration of the program, you had a 48% increase in programs with an incredible amount of scale-up that happened with very little additional investment to the program. And in addition, there's huge cost reductions, so 41% decrease, and this is from Nigeria, by going from vertical programs to integrated programs. So by improving the efficiencies of our program, not only do we reach more, but we have a better case to make for our investment and leveraging additional resources. So this integration is true for NTDs, but not only NTDs. We can also look at this beyond here. Vitamin A, this is for tuberculosis, net distribution for malaria, and malaria home management. This was a project done in Nigeria, and it showed that they decreased costs by 50%, and they increased their coverage of all of these by looking at this as an integrated platform. So this slide has got a lot of things, but it just basically has diseases across the top and all of the different program areas. So it's not only about the time that you go to hand a pill to somebody or go to test them for sleeping sickness, but there are many different points at which programs have opportunities for integration. And looking at each one of those times you reach a community as an opportunity to do more, we can have a lot more reach. So switching the lens from program to to countries. There are certain countries that have the largest burden of disease, and so if we start to look at these, the national approaches may seem to make sense. We have 10 countries that account for over 70% of the burden of disease, and so if we look at this and start to think about these countries, and where do dollars go? Where are dollars coming from now? Here you have endemic country health spending. So the amount of increase that we see that's the greatest in new resources coming into this space is from endemic countries in health spending. So 24% increase. And this is going from 2009 to 2012. Similarly, 2009 to 2012 here, philanthropies increased 12%, where overall development funds have basically remained pretty stable over time. So our newer money that's coming in is endemic countries and in philanthropy. So if we take and move from that, this is looking at those top burdens. So this is the DALYs, or the disease burden within countries, and this is the country's health budget's increase. So we see that some of our countries with the heaviest burden actually have had some of the biggest increase in health investments. So working with these countries to actually leverage those dollars to get them into NTD programs could also decrease that deficit and also be a very compelling case for other donors to come in, matching donor dollars from the countries, actually paying for their own programs. So finally, there's not just dollars that are within governments, but also within high net worth individuals or those who have means within national settings. So this is donors within, with potential for being philanthropists within the countries. So high net worth individuals, that's what that stands for. In India, Russia, Brazil, and China, and you see that this number is increasing. Here, similarly so this is inside of endemic countries. Outside of endemic countries, Australia, Canada, and Germany, and then philanthropy within UK and US. So there are dollars that not only could come from external, but also internal to the countries and leverage to support programs in their own countries. So with that, that's just a couple of different data points drawn from a couple of different things that we've done, trying to squeeze it into 10 minutes and not take away from my other panelists. But the basic piece is that we have success here. We have a lot of success to sell, and we're selling this on behalf of people who do not have a voice in this conversation. So it's our obligation to take these and make it go further. The other piece is that to scale up, we really need to focus on this increased efficiency of programs, because that lets every dollar go further and makes a great business case. The second thing is aligned advocacy, and if we align our advocacy, we can have our voice go further. And increasing these resources, both from having our core donors remain, getting new donors, looking at domestic resources, and leveraging other sectors, including water sanitation, malaria, et cetera, as they move forward. And that's what I have. Thank you.